Morning and welcome everybody. Apologies. My name is Raj Jain. I'm the chair of the Integrated Care Board, and it's great to see so many members of our public and other people who are interested in coming to view this meeting of the Integrated Care Board. I'm going to ask very, very quickly for people to introduce themselves, starting with John. John?
Thanks. Morning, everyone. I'm John Llewellyn. I'm the Chief Digital Officer for the Integrated Care Board.
Good morning. I'm Steve Broomhead. I'm Chief Executive of Warrington Borough Council. I represent the interests of the 3 councils in Cheshire on this board.
Good morning. I'm Louise Barry. I'm Chief Exec of Healthwatch Cheshire, and I represent the 9 Healthwatch across Cheshire and Merseyside.
Good morning. I'm Anthony Middleton. I'm the Director of Performance and Planning for NHS Cheshire and Merseyside.
Tony Foy, Non-Exec Director of the ICB.
Good morning, Chris Smoser. I'm the Chief People Officer for the ICB.
Good morning, I'm Joe Rafferty. I'm a partner member representing the Mental Health, Learning Disability and Community Services Collaborative.
Good morning, my name's Anne Moore. I'm Chief Executive of St Helens and Knowsley and Southport and Ormskirk Hospitals, and I'm the lead for the Cheshire and Mersey Acute and Specialist Trust Provider Collaborative and a partner member.
Good morning, I'm Rowan Pritchard-Jones. I'm the Medical Director for Cheshire and Merseyside.
Hello, my name's Claire Wilson and I'm the Finance Director for Cheshire and Merseyside ICS. Hello, I'm Chris Douglas. I'm the Director of Nursing and Care at the ICS.
Good morning, I'm Graham Irwin, Chief Executive.
Good morning, I'm Claire Watson. I'm the Assistant Chief Executive.
Good morning, everybody. I'm Carol Allen and I'm taking the notes today.
Okay, good morning. My name is Mark Wilkinson. I'm the Place Director for Cheshire East.
Good morning. I'm not Lorraine O'Donnell. I'm Helen Charlesworth-May. I'm the Executive Director for Adults Health and Integration at Cheshire East Council.
Hello, I am Erica Morris and I'm a Non-Exec Director.
Good morning, everyone. My name's Adam Irvin. I'm a Primary Care Partner member and my background's Community Pharmacy.
Good morning. I'm Fiona Lemons. I'm a GP and Associate Medical Director.
Good morning, my name is Ruth Duplessis. I'm Director of Public Health for St Helens Council, so representing both Public Health and Mark Palethorpe as Place Director from St Helens.
Good morning everybody, my name's Chris Hart. I'm the Director of the Cheshire East Social Action Partnership representing the voluntary community faith and social enterprise sector in Cheshire East. Thank you.
Hi everybody, my name is Catherine Sullivan. I'm the Chief Exec of CVS Cheshire East, one of the infrastructure organisations in Cheshire East.
Thank you. We're delighted to be here today in Carew. Thank you, Mark and Helen, for hosting us today, and we look forward to hearing more from you shortly. Can I take board members to the minutes of the last meeting and seek any corrections, questions, comments before seeking your approval for them?
Chair, if I may.
Yes.
Chair, I think we should note that my recollection is Councillor Cummings was present, and he's recorded as an apology in the minutes. And if I go down to the minutes that reflects the report of the Chief Executive last time, part way down the second page where it says the third item, and it talks about the announced budget, it should say the recently announced mini-budget, and the government's letter setting out requirements of the NHS. Sorry, just being a bit pedantic on that one, if you don't mind.
Thank you. Any other comments before I seek your approval? Adam?
Yeah, just one for me, Raj. There's a comment I made around the People Board update, and it's just slightly been misrecorded. I said I'd welcome more work on including more of primary care, not just PCNs. And it's ended up as just including PCNs.
Thanks, Adam. An important one. Thank you. Can I seek your approval for the minutes with those corrections? Yes, please. Yes, thank you. And the board action and decision logs are there for your noting, unless there's any corrections or updates you want to give. I'll move on to agenda item 5, the report of the Chief Exec.
Thank you, Chair. As people will know from previous meetings, I'm not going to go through all of the items, but happy that either I or other executive colleagues will respond to questions on them. I will just highlight three bits from the paper, though. The first is our internal staff consultation. People will know that the ICB came together with the component parts of the 9 former CCGs and also a range of staff who were employed centrally as part of the ICS. We have now commenced a consultation process with our staff to put together a single management structure, a management structure that reflects what we're going to do corporately and what we're going to do in place. It's important that the board are aware of this. This is a difficult time for our staff. It creates uncertainty. And whilst we have the express wish of ensuring a great degree of efficiency and economy can be found and an overall reduction in time of our management costs, we have also been very careful over time to hold a number of vacancies, and therefore we expect the outcome to be that there will still be a job for every person who is currently substantially employed by the organisation. But all the same, it is a process of change and it is very difficult for people, and we wanted the board to note that. The second point that I wanted to draw to your attention is the COVID booster campaign. That's now underway. Every time we have had a new release and another step up of the COVID booster campaign, I have been so impressed by all of the people at the front line delivery point and also our team that have arranged and organised this. But I fear that the public's appetite for a further vaccination may be waning. So everything that we can do to continue to promote people staying protected, and we have already heard this year concerns that if flu and another spike in COVID were to hit at the same time, that would be particularly devastating for the individuals in those circumstances, but also the impact on frontline NHS services would be significant and difficult for us to cope with. So everything that we can possibly do to promote the COVID booster campaign will be done, including in bringing it to your attention today. I also want to say to people that the flu season will be upon us soon, and I would urge everybody to also get their flu vaccine. The eligibility criteria is again dropped, so more people than ever are eligible to have that and to receive that level of protection. And one of the things that we'll bring back here in future monitoring reports is to let you know how all of our hospitals are doing in terms of the level of vaccination that they achieve with frontline staff, because again, keeping our staff at work but also protecting the patients we see is fundamentally important. And then third and finally, of items I was just going to highlight to you was to confirm that our colleagues at Liverpool University Hospitals have now successfully made the transition into the new hospital. That took place over a phased period of time, with the last move being the close down of the previous medical admissions units. And again, that was undertaken in a policy that nobody who was about to be discharged from hospital should move from one hospital to the next hospital and then be discharged. So from the point that that exercise started, they tried to make sure that anybody admitted to the new hospital was a new hospital patient, and the people who remained in the old hospital would go home from there. A very successful programme of work, and we should record our congratulations to our colleagues at Liverpool University Hospitals Trust for what they've achieved in that regard. Happy to take questions on those or any other items, Chair.
Thanks, Graham. Any questions? Steve?
Thank you very much, Graham. First one, paragraph 14, the link between health and economic growth. Every pound invested generates £4 of economic benefit. Good to see that. Even better to learn that we're now going to have on the board of the Health and Care Partnership representatives from Place for Cheshire, and for Merseyside 2 representatives. So you're going to have people involved there who will be looking at the economic growth agenda. So that's really good, so thank you for that. Question about the social care discharge fund, Graham. I think at the last meeting I raised the issue of the fact that government had indicated there'd be £500 million made available to assist with the gridlock that's taking place in hospitals around delayed discharge and getting people into community care. I know it's difficult to know who the Secretary of State is, but I think I now understand it's Stephen Barclay, who has a good Merseyside heritage and background. We lack clarity about where that money is, whose money is it, how can we access it, because we have got gridlock in our hospitals, Graham. As I think, as you know, CQC report indicated that very, very recently. So can we find out more, please, about this fund? Is it going to be made available before Christmas? Because councils are wanting to engage in an integrative way with the NHS to get this thing moving.
On the more general point of the gridlock within our systems and the need for us to discharge more people to their own homes, Anthony will talk about that later when he does the performance and the winter planning reports. But you're referring specifically to an announcement the government made of £500 million to support the care system for this winter. I think we do know where the money is coming from, and we do know where that money sits at the moment. But I don't think that's the nature of this board to discuss that. We do know that there are high-level proposals in place as to how that money should be deployed. If Cheshire and Merseyside get their fair share of that money, it'll be about £26 million. And our understanding at the moment is about 40% of that money will go to support the marketplace, i.e. to enable more staff working in that area to receive a decent wage that will allow retention of staff working in that sector, with the other 60% of that money available to effectively buy more packages of care so that we can get more people discharged from hospital. We don't know yet whether or not that money is going to be transferred directly to local authorities or whether that's going to be passported through the NHS through the Better Care Fund. But my sense is each of our places should have a plan in place now as to what they would spend that money on, and should only be waiting for somebody to push the button and give us the green light to go. I think it is one of the things that I suspect is sitting in the in-tray of the new Secretary of State for sign-off. So I'm optimistic that we will get clarity, and clarity very soon.
Thanks, Graham. Ruth?
Yeah, thank you, Chair. It was just to highlight the good work of the Live Well bus that we've had operating across Cheshire and Merseyside. I believe that Dame Jenny Harries, the Chief Exec of UCSA, and also Lord Kamlesh Patel, the Chair of Social Care in England, came up to see the bus in Chester on Monday, and they've already completed over 3,000 COVID vaccinations and quite a number of health checks.
Thank you. Joe?
Can I just ask a question about the internal consultation piece that's going on around the development of the wider team? What sort of steps have been taken to maintain staff morale, I suppose, as I go through this really difficult level of change? I've experienced this myself a number of times. I know you have, Graham. And it is a very difficult time, no matter, even if we guarantee people a role, it's about sort of pride in work and all of those sorts of things.
Chris, would you like to comment?
Thank you, Chair. I think it's a really important point. So the structures have been developed very much in partnership with staff. So the place directors, the corporate directors have been working with the subject matter experts in many cases to develop those strategies. We have got quite a wide range of support available for staff in terms of health and well-being. Over the next 3 weeks whilst the consultation's live, there are at least 3 sessions with place directors in the individual places. We've got HR support, HR drop-in sessions, we've got question and answer sessions, and we've been doing what we call our We Are One briefings where staff get the opportunity to ask questions. We've made sure we've enhanced our occupational health offer through our employee assist programmes. And as Graham said, we have guaranteed everyone who's a permanent member of staff a post at the end of this. But we recognise, even with those assurances, that some staff will still feel very anxious, and it's important that we do support them through that process.
Thanks, Chris. Graham, did you want to say something?
Joe quite rightly points out that the NHS does seem to go through this from time to time, and therefore it's something that we've experienced before. I think one of the things that we're conscious of is we're not in touch with our staff in the same way as we used to be, or the last time we did this. Most of our staff are still working in some form of hybrid, maybe 2 days in the office each week and other days working from home. So we have quite deliberately been bringing staff together for face-to-face briefings, because it's really, really important that we connect with people, and you get a different sense, don't you, from the body language and the dynamic of when you have people in the room. And sometimes when we do online briefings and we have 400 people, you just can't pick up the tone in the way that you should do.
Thanks, Graham. Just a couple of questions from me, Graham, or one question now, one comment. Item 9, the citizens panel. Does that include children? If not, do we have a children's panel?
I'm gonna look to the audience and Maria to help out here, if you wouldn't mind, Maria.
Absolutely. The citizens panel, as described, does not, or it links into the panels at place. So it's almost like an octopus with tentacles. So that's where the children, young people is picked up at place and feeds through.
Okay. Well, could I ask us to think about parity for children then, in terms of whether it's appropriate to have a Cheshire and Merseyside Citizens Children panel, if that's the right phrase?
Yeah, absolutely.
Yeah, thank you. And the other one was just a comment. I'm not going to ask people to reveal their status, but people around this table represent a lot of organisations, and we have responsibilities, I think, about promoting the vaccination programmes. We know that the stats, as Graham's just said, are really low at this moment in comparison with previous years, especially around flu, especially amongst our staff. We know the NHS figures. Steve, I'm not sure what it's like in local authority, but I would urge us to use our positions to promote vaccinations as strongly as possible. It's in everybody's interest. Thank you. So happy to move on. We'll go to Mark and Helen, I think.
Okay, cheers. Thank you very much, Chair. So good morning, everyone, and welcome to Cheshire East. I'm afraid that Lorraine O'Donnell has had to send her apologies today, and I know that she's really disappointed that she's not able to be here, but I'm really pleased that Helen is able to join us. As place leaders in Cheshire East, we've given some considerable thought to what we want to say to you today. And the themes that we're going to introduce now run through not only this presentation, but also our patient story and the marketplace at lunchtime. Next slide, please. So, in some ways, we are doing relatively well in Cheshire East, but there is a real danger that significantly advantaged areas mask the challenges facing significantly disadvantaged areas. And that is why we are in Crewe and talking about Crewe. But there is also now a potential moment for this town, and that's with the planned arrival of HS2. We're committed to the economic regeneration of Crewe as a town, but also ensuring that those economic regeneration benefits benefit the people and businesses of this town and also support health regeneration. So that's the overall theme that's going to run through, as I say, this presentation, the story and the marketplace. But I'll hand over to Helen to introduce Cheshire East as a place. Thank you.
So this is Cheshire East Place. We are a population of about 400,000. We have the biggest gap between health inequalities in Cheshire and Mersey. So in the north of the borough, Knutsford, Wilmslow, Poynton, you have some of the most affluent places in the country. Places there are as wealthy as anywhere in Surrey and those big southern counties. But in Crewe, we have some of the greatest deprivation in Cheshire and Mersey, akin to anything in our poorest parts of Cheshire and Mersey, and one of the poorest places in the country. It takes, I have been told today, although I think this depends on what speed you drive at, about an hour and 10 minutes to drive from the north of the borough to the south of the borough. So we're quite a big place. And depending on how you've come here today, you'll see that we are quite a rural place. Large agricultural businesses around, although quite well connected. And the thing that Crewe really has going for it is its connections. It's one of the most heavily railway connected places in the country. But in talking about those connections, we shouldn't miss the fact that in that southern part of the borough, where you can see the name of Audlam, and then you've got a mass without any of our town names. That's a big rural area. It's a big rural area that attracts older people to retire. And it's a big rural area with very poor connectivity. Because anybody who watches local government at all and has watched it over the last 10 years, you will know that the big conversation has been about how budget reductions have impacted on children's and adult services. But the bit that nobody really talks about is how that has impacted on transport services which are commissioned within local authorities. So transport is a very, very significant issue for the people who live in Cheshire East if they don't live in one of those towns. So this is where Cheshire East sits within its immediate neighbours. So we are surrounded by almost 10 local authorities. I say almost because number 8 doesn't quite touch us, but is a local authority with whom we do a lot of business. So we're surrounded by 10 local authorities. There are 4 ICBs around us, of which we're part of one. And the people who live in Cheshire East go to a variety of NHS services and service providers. So we have a big flow into Stoke-on-Trent, big flow to Staffordshire, big flow into Greater Manchester, as you can imagine. And some of those people down in the far southwest of the borough go over to Shropshire. So the really important thing for us is how Cheshire and Mersey integrated care system develops, conscious of the fact that we look to a variety of different directions. And there are distinct characteristics of places that are on the periphery of larger agglomerations or geographically. We are not a peripheral place based on our geographical locality, but we very much are a peripheral place in the context of a Cheshire and Mersey footprint. So this is our population, and I can't read that without my spectacles, so you'll have to excuse me. So we just had the census. And the key thing that came out of the census for us is we're growing, our population is growing faster than we thought, but it is our over 65s that are growing fastest of all. And anybody who works in our services that work with older people will know that the strongest correlation between spend in adult social care and health is between the growth of the population of the over 80s. So we're very conscious that we're starting to see that context. However, we do also have young people, and really agree with you that we need a mechanism for talking to young people as well as older people. In Cheshire East, and I in particular, because of my service, tend to forget that we have lots of children and that those children need to be supported into good jobs. And in that context, we have two really great colleges who are working with us to invest in apprenticeships for the future. We are the third largest local authority in the northwest, 15th in the country, and we are a unitary, which means that we're responsible for a whole gamut of services that in two-tier authorities are sometimes split between counties and districts. We are a joint administration of Labour and independent councillors. The largest party in Cheshire East is Conservative, and the Conservatives have held power in Cheshire East until the last election. The Council has made a commitment to being carbon neutral by 2025, and we are looking at how Cheshire East as a place can be carbon neutral by 2040. We provide a wide range of services, and actually we have one of the biggest planning services in the country. That is driven by both businesses, but largely by individuals and residences, and is very much a factor of our very wealthy population. Mark.
Thank you. So we want to paint a picture of relatively strong foundations, and nowhere are the foundations in Cheshire East as strong as they are in primary care, and actually as a related point also our clinical leadership. So to evidence that, I wanted to share some information you've got on this slide here based on the last survey of patient experiences of primary care, which was published over the summer, and you can see that our performance in Cheshire East is ahead of both Cheshire and Merseyside and also England averages. I don't, however, want to give the impression of good performance across the board. The fragile nature of services at Macclesfield District General Hospital has been referenced before to this board, and Leighton Hospital here in Crewe is under significant pressure in terms of its emergency department and other associated measures. As of yesterday, 125 patients were in the acute hospital in Leighton without the criteria to reside there. Our view is that this is a risk issue for the system, and we're seeking to expand provision of domiciliary care, but also to transform the way in which it is accessed. Nevertheless, we are doing well on most measures compared to national and regional comparators, but this is because of significant wealth, as Helen's referenced, masking large areas of deprivation. Next slide, please. So we talk about something called the tartan rug, and it's the pattern and the colours that are important on this slide, not the numbers. So across the top, we've got all the Cheshire East electoral wards, and down the left, we've got the range of population health indicators. And the colours compare our Cheshire East performance to the rest of England. And I think what becomes immediately obvious is the most tremendous variation, with the reds of predominantly Crewe on the left-hand side there, but also Macclesfield towards the right-hand side, contrasting with the greens of Knutsford and Wilmslow. So this is the key point that we want to get across with this information, to beware of averages, and that we should all get more granular and apply judgment in our approach. So we've judged the best thing that we can do today is to talk to you about Crewe. Next slide, please. Today we're in some of the most deprived wards to be found anywhere in England, absolutely in the bottom 10% if we look at it on a ward basis. And Crewe isn't small, it's 88,000 people, it's approaching a quarter of Cheshire East. Another way of thinking about the challenges facing the people of Crewe is to relate their health experiences and their use of the NHS to a village of 100 people. Next slide, please. So Crewe GHR, the GHR stands for Grosvenor, Hungerford and Rope Green. Those are three of our practices in this area, and together they comprise one of the two Crewe-based primary care networks. And if that PCN was a village of 100 people, 18 would have depression, 6 would have diabetes. And in the year, the 100 people would on average see their GP every quarter. The vast majority would have an outpatient appointment. And from this village of 100 people, there'd be 10 999 calls each year, 38 A&E attendances requiring 15 emergency admissions, and all this from just 100 people in a single year. So far, we've tended to talk about population need in the way that I think the NHS really tends to think about it. But in Cheshire East, we're starting to look at our services through the lens of what people want as well as what they need. I think if it was a Venn diagram, the two circles of want and need would overlap quite a lot, but not entirely. And so in terms of thinking about our service improvement agenda, we want to consider wants as well as needs. Next slide, please. We've worked with data analysts to develop 4 core segments in terms of the wants of the people we serve. So the data tells us that at any stage, when you're actively using the NHS, you're likely to be in one of 4 categories. Help me stay well, what's wrong with me, fix me, or end of life. And using these 4 segments, it's possible to discern what patients look for. And unsurprisingly, they've got different needs according to different segments. So if you're in the Fix Me segment, you typically need focused care to get better after a definitive diagnosis. You want accessibility to be seen quickly, expertise in a pleasant environment, and you'll expect a rapid return to normal life. But if you're in the Help Me to Stay Well segment, you're seeking services geared to support you to manage your well-being, but also your exacerbations, perhaps of your long-term conditions. You want services fitting around your life. You're looking for trust and compassion, support for self-management, and a long-term relationship with your clinicians will be particularly important to you. So we want to use these data-driven insights combined with judgment as we seek to improve the services we deliver, with a particular focus on the most disadvantaged people in our communities, like the people that live in places like Crewe. So at the same time as being clear about the challenges facing the people here, we're excited about the plans for future growth. Helen.
Thank you. Crewe is at a really exciting point in its history, actually, and we have once in a generation opportunity to make a significant impact on the lives of people who live in Crewe, not through anything that we will do as health and care services, but through the opportunity for growth that is emerging in Crewe. So we talked about the fact that we have a growing older population. Crewe is the place that has a young population and a growing young population. Land values are lower here, and it has an historical industrial base, but that historical industrial base is growing into a current contemporary industrial base. So we have Bentley, and Crewe is the place in the whole of the Bentley footprint that won the opportunity to build and develop this year's electric vehicle. That was down to the skills and the creativity of people working in Crewe at Bentley. We have commitment to an HS2 hub station, and that will be at least 10 years ahead of Manchester. Now, HS2 at the moment, clearly people are looking at those figures, but what that will do for the opportunity and connectivity in Crewe is beyond anything we had imagined in the last 10 years. Some of you, all of you, I hope, will have voted for Crewe to be the headquarters of Great British Railways. I think that is up in the air at the moment, but it was the only location in the northwest that was shortlisted. And the education infrastructure is absolutely superb. I was lucky enough to go to Crewe College a couple of weeks ago, and the facilities that they have available to them are amazing, invested in by local businesses, and they have chosen to invest in ensuring that every young person gets free travel to the college because of the impact that will have on educational equality and educational attainment levels. Move on. So where we're at as Cheshire East is that we want to look at everything we do through the lens of health inequality. How we support people to look after themselves, how we support them to access services more appropriately and easily, but how we build an environment that enables them to flourish. That will be built on our foundations of good primary care, but will be primarily because people are supported to live good economic lives leading to good, healthy lives. Can we? And that's it. Thank you very much.
Thank you, Helen. Mark, can we go straight into the resident story, do you think? And then perhaps we'll take some comments at the end of that.
Yeah, absolutely. Okay, thank you. So the College of Medicine is running a Beyond Pills campaign that highlights the importance of social prescribing and the contribution that social prescribing can make to better outcomes, to fewer side effects, to improve mental, physical and social health, and also deliver major savings to the NHS. Social prescribing involves a patient being referred to a link worker who's a non-clinical professional who takes time with the patient to co-design a social intervention to address their specific issues. Interventions can range from encouragement to exercise or improve nutrition, join an arts group, quite a wide range. It's worth saying that social prescribing also aligns directly with the Fuller report, which was published, I think, early this year, which calls for a significant cultural shift towards a more psychosocial model of care that takes a more holistic approach to supporting the health and well-being of a community. And that's what we're doing here in Cheshire East, and that's the subject of our patient story. Pathways is an innovative local social enterprise which has developed an alternative solution service. They're providing a hands-on social prescribing programme supporting individuals who live in Cheshire and who are registered with our local GP practices. Individuals can be referred into the service via their GP practice, and on referral they're assigned a link worker who provides tailored support. So that's the subject of this very brief resident story. So if we could have the video, please. Thank you.
Can I just say we were referred to come to Hayley because we were upset with everything. We were in a hole and didn't know how to get out of it. With Alistair's mental health, his physical health and my mental health as well. And we were referred to see Hayley, and she started the ball rolling, and everything has happened since. We've been in touch with the pharmacist, we've been in touch with the musculoskeletal, we've had mental health come to see us, and she's got a part to play in it. And now we're going to have a meeting with the specialists and the doctors to see where we go with Alistair's condition. In the meantime, I've been in touch with the Stroke Association, the Parkinson's group, and U3A now, and joined Alistair. So we're near on there now. We just need to sort out his medical, and then his mental health can follow through, hopefully.
And I agree with everything my wife said.
And Hayley's absolutely wonderful, and I couldn't have done it without her. I didn't know where to turn.
Thanks, Mark. Really interesting and comprehensive presentation, starkly illustrating the differences that exist, as well as the fantastic opportunities. Can I seek any comments or questions from board members? All suitably impressed. Erica?
Hi, just a couple of points really. It's my locality. So the first one is about workforce. Obviously, I'm well accustomed with the advantages of Bentley and also of the railway here. But we've also got the hospitals, we've got care needs. Just what are the pathways really from the great colleges we've got into that locally against Bentley?
So we're just in the process of setting up what we call the Care Academy. So there are lots of opportunities to bring young people in particular, but not exclusively young people into care roles through apprenticeships, and from there trained in the local authority and then out to other roles. Now, it's not something we've done before. and it is something we're setting up with the college at the moment. It is really important. I've been talking to the principals, and it's really interesting because whilst the pandemic has raised the visibility of care workers, and whilst the pandemic has raised the appreciation, I think is the right way of describing it, of our NHS workers, it's had the opposite effect in terms of talking about care workers. So what young people and their parents in particular, because parents are really important in this, what their parents are seeing are roles that don't necessarily have a career trajectory, roles that are not necessarily valued, and roles that don't necessarily give a good salary and career, a lifetime career. So there is a really important job that we have to do, and will take some time, because what the research is telling us is that we need to get into schools when children are still forming their ideas about what they want to do. So Deborah Woodcock, who's Director of Children's Services, and I have got a plan. There will be some short-term interventions which we hope are beneficial. We'll do those with the colleges. But if we're really serious about growing the care workforce, that is a long-term endeavour.
Steve?
Thank you very much. Very good presentation. Nationally, the Directors of Public Health this week have reported the fact that since 2014, there's been a real terms fall of 25% in the ring-fence grant for public health. How does that affect the challenge of health inequalities here in Cheshire East, and how are you going to deal with it, given the fact that the council's budgets have also fallen probably more than 25% since 2010? What's the plan of the system for challenging and actually getting progress around narrowing the gap in terms of health inequalities?
So I'll start. We've been quite fortunate in that over time we have managed to set some of that money aside for long-term investment in health inequalities. And this year, actually, the committee agreed, Adults and Health Committee of the Council agreed to invest in a pilot for smoking cessation. So we are going to pay people to give up smoking. We're going to try that as a pilot based on the research. People around this table will know the research and understand the potential benefits of that. I think for a local authority, politicians to make that decision was a really far-sighted, thoughtful decision, because it is something that was met with a degree of incredulity in local press. So we are not frightened to look at innovation and take some brave decisions, and we've got some politicians who are prepared to take some brave decisions. But our focus, the purpose of this presentation really, is to set out for you that the gap is so huge in Cheshire East that it can't just be about the council investing in the broader determinants of health. It has to be the totality of us as a system. I'm really clear with my colleagues in the council that I need them to think about every pound they invest to make sure it delivers health improvement and addresses health inequalities. I need to be able to say to them with confidence that our health colleagues sat around the table are doing the same thing.
Thanks, Steve. Oh, thanks, Helen, Mark. Great presentation. We can see those stark differences that you just articulated, Helen. And we look forward to hearing from you in the future in terms of some of those really interesting innovations that you're generating here. So if we're comfortable to move on, we'll move on to the agenda item 8, which is the system finance report.
Thank you. Colleagues will have the paper in the pack, and there's quite a lot of information there, so I'll just draw out a couple of key themes. We had a similar report at the last meeting, so I'll just sort of identify some of the key movements. The position has worsened by £10 million in month across the whole system, so we're now looking at a year-to-date deficit position of £55 million. We still have a plan to deliver a £30 million deficit by the end of the year, so a significant improvement in our run rate would have been required in order to do that. So a £55 million deficit for the first half of the year, and in order to hit our plan, we would need a £20 million deficit for the final 6 months of the year. I'll come on to the risk associated with delivering that shortly. The CIP performance remains really low, and particularly the recurrent elements of CIP. So we are still delivering more than 60% of our CIP as a system non-recurrently, which means that we get one-off benefits this year, and as we go into next year, that will give us a gap that we need to manage. And so we are storing a problem up for the future, and that is a real concern, and was a concern of the Finance Committee when we met earlier this week as well. It is also the focus of a key focus of the meetings that we are having with organisations that are going off track to ensure that they're doing everything they possibly can to build up the level of recurrent savings that they're identifying. I think the final thing just to say is on risk. And I know this committee has asked in the last couple of meetings about the risks associated with delivery of the position by the year end by all the organisations who have set the plan this year. And we are collectively still assessing our unmitigated risk as a system to be £74 million. That is to say that we have got risks of £74 million that we don't yet have a clear solution or mitigation to. And those risks will materialise unless we find a mitigation, and that will give us a negative variance to the plan that we need to achieve by the end of the year. So that's obviously a key area of focus for us as we have our conversations with our individual organisations in the system, including the ICB's own financial risk position, as to how much further what further we can do to mitigate those risks. And the Finance Committee earlier this week talked about how we develop our financial risk reporting, monitoring and understanding as part of our wider risk strategy as a system and as an organisation. So that is an area that we're going to do more work on. We know our key risks are around winter, potential of industrial action, risks around energy and non-pay inflation costs, although I think there are some early signs that energy prices, or certainly gas, is dropping slightly recently, and a number of other operational risks that colleagues are managing across the system, including non-delivery of CIP, which I've already mentioned. So without further action, we're going to end up with a £74 million departure from our plan. I think that we will manage a big chunk of that through the work that we're doing with system partners, and individual organisations will continue to do as well. But there are 3 organisations that are now, we're having active conversations with about the fact that they are going to struggle to deliver the plan that they set at the beginning of the year. And we are having conversations nationally because there will be a national protocol of what needs to be put in place if organisations don't or change their forecast away from their plan. So I'll update more when we meet next, because some of those conversations might have crystallised by then. But there is still a huge amount of work to do in this year on the financial position to put us in a really good place as well for next year, or the best place we can possibly be for next year. So I'll take questions. Thanks, Chair.
Thanks, Claire. Questions? Tony?
Thanks, Claire. We did rehearse some of this at the Finance Committee, but you've articulated in Section 4 a number of the risks around particular providers, and also, if you like, risks by sector. But you also made reference at 4.3 13 about provider agency costs. Just how significant a risk is that if it continues to challenge some particular trusts?
It is a significant risk, and I'm sure some of the organisations around the table may be able to provide some context to the individual challenges they're facing. But it's a risk on a number of fronts, and Chris might have a view as well on the quality aspects of using agency. The best thing is to have recruitment and have permanent staff and substantive staff in post. Clearly, operational pressures on a day-to-day basis means that that is not always possible, and in order to maintain the same staffing levels, agencies are used. I think from a financial perspective, we have been asked, or we are expected to deliver a 10% saving on the levels of agency that we used last year, and at the moment, the forecasts that individual organisations are providing is that given operational pressures, gaps, sickness levels, and slightly higher COVID incidents early on in the year, have meant that the agency costs that we're currently forecasting is more than the expectation that has been set for us nationally. So it is a risk. But I think there's also, I don't know, Chris, whether you want to talk about, it's not just the money, is it? It's much bigger than that.
And I would echo what Claire said around that, but we will need an element of temporary staffing as we move forward because of the workforce gaps that we have. And I think what we need to do is ensure that we have our wards and departments safely staffed. However, to address both agency and our internal bank at the same time is going to be difficult to do. So we would need to focus on how we develop our temporary staff, whether that be within an organisation's own internal bank arrangements or using other agencies to provide their bank. But I think we will continue to see considerable uses of temporary staff as we move forward through the winter months.
Can I just add a supplementary to this question? I think it's going to be important for us as a board to understand the fact that there are more staff in the NHS than we've had pre-COVID. On average, it's 10% more. Where our activity levels are and the correlation with agency and TAMP, intrinsically, is that the right word? There's something that needs to be squared there in terms of that understanding. So, Claire, Chris, perhaps if I could ask through you if we could seek to understand that at the next board. Yep. Thank you. Any further questions? Steve?
Just on page 74, Appendix 1, the CCG planned deficits. There's a planned deficit here of £27 million for Cheshire CCG or place. Should we be concerned about that, or is it a result of all the demands and pressures that are being made on the services? Is that likely to recover? It's a big number and it stands out against all the other 9 places that we're responsible for.
Mark, are you happy to answer that?
Yeah, so I think we should be concerned about it. I think the former Cheshire CCG has had, or the Cheshire Place system has had a financial deficit for a number of years. I think that in large part that relates to the financial position of East Cheshire NHS Trust, which declared itself to be not financially viable back in 2015, and that was the trigger for a whole set of external reviews looking at services to support the population in the east of Cheshire East. That's culminated most recently in the work with Stockport against a list of fragile services. So certainly under the pre-pandemic financial regimes for the NHS, that led to a financial deficit for East Cheshire Trust, which is the significant driver behind the deficit that you're quoting there, Stephen. I think as Claire's referenced in the paper, we have submitted a financial recovery plan setting out what we can do and some limited progress that we can make in year. But I think some of the longer term and more strategic challenges remain. I'm not sure if you'd want to add anything else, Claire.
No, yeah, absolutely. I think we probably need to think about, and this is something we can talk about before the next meeting, is how we bring to this board's attention the recovery plans from the places that have been developed, because we do have two places that have developed them, and we probably need to, I can incorporate that into my report next month.
Thanks. Graham?
This report represents the kind of transition year from the way we existed with CCGs into the new environment. It's really important that we see that legacy position, and it's really important that we use this information and this comparative information to drive the best use of money that we've possibly got. And these deficits against these former CCGs, what's really important is CCGs were funded against a formula, and whatever you think about that formula, the formula was intended to give fair resources to each of the places. So it's going to be really important in our strategy moving forward that we hold on to an element of spend by place, because it will be really important that we show that we are dedicating fair and appropriate shares of resources to each of our places. So one, see this as part of the transition, but two, also see the importance of us being able to say, are any of our places consuming more than their fair share? Because when a place does consume more than its fair share, given our overall duty to balance our books, what that effectively tells us is they're spending somebody else's money, and they're spending somebody else's money from somewhere else in Cheshire and Merseyside, and we've got to ensure fairness and equity.
Thanks, Graham. Just before I bring in Joe, could I just say to the members of the public, I should have said at the beginning of this meeting that this is a meeting in public. And we don't have the opportunity for members of the public, I can see you put your hands up, to ask questions at this meeting. We do have a couple of processes that we could use to answer your questions. One is there is a formal process where you could submit questions, or if you welcome to stay at the end of the meeting, and I'll come and see you and find out what your question is, if that's okay. Oh, okay. Apologies. Right. Right, that's a really good hand up. Can we make sure we speak into the microphones, please, so that everybody has the opportunity to hear? Joe?
Thanks very much, Raj. Can you hear me? Okay. My question relates to provider efficiencies, section 5.3. Claire, it's really to ask, I mean, it is where it is, but it's to ask about the plan to get to more recurrent rather than non-recurrent savings and what that plan looks like.
Yeah, so I think there's a number of elements to this. I think efficiencies, there will always be a need for individual provider organisations to develop their own internal efficiency plan. That board will oversee and gains assurance on that we, continuously monitor in relation to the way that we hold to account those organisations financially. And that will have to deal with productivity challenges within the organisation, particularly as Raj has said, over the last 2 to 3 years, productivity in the NHS has reduced significantly. But there's, I think, probably another two categories of efficiencies. There is those then that will only be addressed by taking a wider view across a system or a place, or the way that we do things, patient flows across wider geography, transformational change, which has a slightly longer lead-in time. So I think the plans are being developed by individual organisations, but they're not developing fast enough in many cases. I think there are some organisations that have made great progress on that this year. And I hope you don't mind me saying, but you've done all of your CIP has been recurrent, hasn't it, that you delivered, and it's on plan. So I think we've got something to do on sharing some of that information, sharing the approaches. I think We are also looking at, across the system, re-establishing and reinvigorating the Carter at scale, or the collaboration at scale work streams. So we're going to look at drugs costs, we're going to look at collaborative bank again, and procurement at scale, and financial systems at scale. We've got an SRO identified to lead that, and we'll pick that up over the next couple of weeks as part of the workshop work that we're doing with chief executives. And, you know, and then over and above that, there are some other strategic pieces of work across the system, such as, you know, all of the work that Liverpool is doing across place, or Southport is doing, you know, across place around the transformation there. So there are different elements to this, but I do come back to the fact that there is more work to do within individual organisations to progress their own internal efficiency plans, on the back of the fact that over the last 2 to 3 years, we haven't had CIPs delivered in most organisations at all. So there should be opportunity there for recurrent savings.
Thank you. Can we move on, if that's okay? And I'll go on to agenda item 9, which is the quality and performance report, which is Tony, I think, leading on.
It is, thanks, Chairman, and hopefully everyone can hear. The report this month includes not only a range of sentinel metrics that many board members will be becoming accustomed to, it also now includes a narrative to support some of that. But I will give an overview of some of the key sections, particularly picking up on some of the comments that have been made earlier on. So if I look first of all at the urgent care system, and particular reference, I guess, to Steve's comments earlier on about it being gridlocked, I think that's a fair summary of particularly the hospital sector right now. But if I look further along the patient pathway, or further upstream on the patient pathway, if we look at the demands that we're seeing on primary care, if we look at the demands that we're seeing against 999 and 111 calls, that is acutely up on pre-COVID periods. But the efforts that have been made within those sectors, for instance, different ways of working in primary care to include other health professionals, or the use of telephone clinics, etc., on the whole are meeting some of that increased demand. And if we look at the 999 responses, there's been a number of interventions and improvements in the way in which services are provided and accessible to ambulance colleagues, which means that for the first time last week, actually, our ambulance service provider reported that less than 50% of the 999 calls that they received were actually conveyed to hospital, and we've never seen a level as low as that before. And as I say, that will be a credit not only to the development of skills within the ambulance service to deal with people in their home or the roadside, etc., but also the range of services that they can now access as an alternative to hospital conveyance. So when we do move to that hospital sector and ask why we have this position of gridlock, because it isn't necessarily a position born out of increased demand. Both attendances and A&E admissions are relatively static over the past 12 or so, and you can see that in some of the metrics that's within the paper. But if I take you to the bottom of page 92, where we look at the bed occupancy level within the acute sector, and the number of patients no longer meeting the criteria to reside, which I'll explain in a bit more detail shortly, is that you can see that exponential rise in bed occupancy. And what I'd stress even on this graph is that that's the bed occupancy in aggregate for all of the hospitals across Cheshire and Mersey. So 93% includes some of our specialist trusts, where occupancy level is lower. They don't have the A&E facilities like others. If you actually look at the acute district general hospitals, they are routinely reporting anywhere between 97 and 100% occupancy all the time. And that excludes a number of patients that are either on their way in via ambulance or actually in the A&E department awaiting admission. Now, some of that occupancy will be driven by what we've seen as continual waves of COVID, which elongates length of stay and obviously puts further pressures on the bed stock. But as you can see from the bottom of that chart on page 92, the starkest change is the number of people that are still resident within an acute setting that actually require some form of social care support, predominantly domiciliary care, and Mark referenced earlier in his presentation about some of the efforts that's being made at place to not only increase that capacity, but to provide domiciliary care in a very different way, and that's the starkest point. Now, I wasn't necessarily going to cover at this particular point a great deal of detail into the intervention, because I intend to try and pick that up in the later paper if that's okay. And I was going to move on to elective. So having painted a very hopefully clear picture of just a level of extreme pressure within the urgent care system, I think it's a great credit to then look to the elective delivery that we're seeing across Cheshire and Merseyside. And we're starting to see some real change and improvement in addressing some of the backlogs that were created during the COVID 2-year period when a lot of elective activity was suspended. So we talked a couple of months ago about that we'd hit the objective of eliminating anyone that was waiting over 2 years for surgery, 104 weeks, and we have a trajectory to take us to no more than 18 months by the end of March 23, and you can see the position in terms of numbers against what's titled the 78-week waiter. You can start to see that that's coming down. That's a credit to everything that's being done in a very collaborative way, and I think we heard last month in a level of detail from Anne on the work of that provider collaborative, and particularly that elective programme. Not only in the use of mutual aid, but also some of the effort that's being taken to increase productivity through theatres, etc., and clinical review, and it's that is a significant factor in some of the improvements we can see there. In terms of cancer, that is another position that was impacted during COVID. We saw a significant drop-off in referrals during the COVID period, even though cancer services were maintained. And then as we've come out of lockdown, we've seen a bounce back in terms of the number of referrals that we see coming into the system. I think the position that we're seeing now, which is nearly 20% higher in the number of referrals, might actually be the new norm. We don't seem to be seeing a drop-off in that in recent months. And in response to that, predominantly the Cancer Alliance on behalf of Cheshire and Mersey, again working collaboratively across all sectors and providers, has been working to increase capacity, is using shared waiting lists, and has mobilised a real significant increase in diagnostic capacity. If we look at the volume of diagnostic testing that's taking place now across Cheshire and Mersey, it's 18% higher than what it was pre-COVID, and you know, there are significant levels of volumes associated with that. So what we see there is a position where we have seen a backlog grow. There is a robust but very ambitious big target that we're working towards in terms of trying to get that backlog level down to a level comparable with pre-COVID by the end of March 23. That would allow us to deliver the 62-day standard, and that's a really key clinical measure. This is the measure from when a patient is referred to the system, having received their final definitive treatment for cancer within a 2-month time frame. And we know that achieving that objective has a significant impact on life expectancy, and that's where the efforts lie at the minute. In terms of mental health, I think in terms of urgent care, everything that I've just said, predominantly acute, can be absolutely echoed in terms of mental health provision. We're looking at a system that equally has the same bed pressures, equally has that growth in demand, and equally has the same workforce challenges in delivering a whole range of response to that. Again, I'll mention some of that within the winter planning paper later on, but also just for note, and I think it's picked up within the performance and quality committee report, one particular element that was focused in on a couple of months ago in terms of annual health assessments. We covered that there, and I'll leave us when we get to that section to report on that. So that's the overall appraise. Quite happy to take any questions on any of that or anything else that's not in the paper.
Thanks, Anthony. Do we have any questions? I'll just ask a couple. Well, probably one for Chris and Rowan. Given that picture about 12-hour delays in A&E, the obvious question is about safety and understanding our keeping appropriate surveillance of the safety of patients as they incur those additional long waits. Do we have a sight on that?
Yes, we do. As a professional body, we meet weekly at the moment to consider the issues around quality and safety within the organisations, and about how we report and how we learn from incidents that have occurred. Obviously, it's around listening to the patient experience as well and how we improve that. I think that there is obviously further work to do on that. I think there are some challenging times to come within the winter in respect of where we may have to look at the risk and how we share the risk within the organisation. So whether that be from the front door within the emergency department through into the organisation. But we have got sight on that.
Thanks, Chris. Where my mind went was about the additional pressures in winter, and I think in previous years there has been a systematic approach to seeking to understand the experience and safety of patients and for long hour waits, and a mechanism that boards, most certainly Anne, used to get, that gave us some assurance about that issue about safety for long waiters. I remember that wrong, maybe.
Well, it's probably the biggest stress we've got at the moment is that the worry is the cumulative effect. So here we are with the problems we've got now, and we're not even in the winter yet. So I guess one of the things that's probably causing us most concern is what happens next in terms of, we're already beginning to hear reports of situations whereby, hospitals are not even being able to find space, never mind the staff. So we are anxious as we go into the winter that we'll get even more cumulative effect than we've got now. And the big issue here is keeping the patients safe. And as Chris says, the patient's experience is really not where it needs to be at all. And really, we just need to make sure we're able to provide a sufficiently good service to at least be keeping the patient safe, if we can't really give them a great experience until we find a better way to solve the problem.
Thanks, Anne. Louise?
Yeah, it's just to make the board aware. So Healthwatch Cheshire, Healthwatch Cheshire East, have recently completed an A&E watch in Leighton Hospital, where we went in over 5 different periods of time over a week to look at the experience of people accessing the A&E department, but actually to also look at where they were presenting from, why they were presenting, where else they've tried. So that report is, well, it was finished yesterday. So that report is going back into went back into Leighton yesterday, late on. And I think, we are seeing some really awful acute entry into acute, the challenges of people. But I think it does need saying that what we also saw was incredibly committed staff that were trying to make the best of the experience for people that were there. So it was people that were compassionate, people that were understanding, the staff were under an incredible amount of pressure. So I think there was frustrations around people not knowing how long they were going to wait. We didn't actually see a great deal of people who had turned up without trying somewhere else first. So there's all sorts of different information we can get, but collectively, Healthwatch can give an insight into those personal stories and personal patient experiences at that point of entry, as well as those that are waiting a long time for treatment out in the community.
Thanks, Louise. That's really useful insight. Anne's point about how the extreme pressure that we are seeing in ED and we don't have any easy answers is hugely relevant to us. I guess as a leadership team, we must do what we can do to support both patients in ED and the staff in ED who are experiencing that extreme pressure. So I thought it was useful just for us to say that. I'm not sure we can magic anything up that hasn't been already thought of or tried. But the acknowledgement, I think, is really, really important, both to our members of the public and to our staff. Just a couple of other questions. One is, on patient-initiated follow-up, it feels as though we could do more. And I would seek, I guess, I can see you nodding, Rowan. I guess we don't need to do more, but there seems a real opportunity for both improved patient experience and allocating our capacity elsewhere. And I I think I'm going to say this at every meeting about the percent of patients with LD who are not having their health check. We can see, you know, the fantastic performance in primary care in terms of the additional people they're seeing, but it feels as though our patients, our people with LD, could be being left behind. So having a focus on that, if I could ask of perhaps through Rowan, Fiona, if you want to.
There is actually, we discussed that at Quality and Performance Committee, and in the highlight report there is some information on it where we had a much more detailed discussion, so we are focused on that.
Okay, it's what we said last month as well, isn't it, Fiona? Is we're not seeing progress, I don't think, in the way that we could see progress.
You won't see progress on that metrics probably until February or March, because it is an annual health check, and practices generally don't do very much in terms of LD annual health checks in September, October, November, because they're doing flu campaigns and dealing with winter pressures, and they tend to push that piece of work into the last quarter of the year. So you'll see that the numbers go up significantly in the last quarter of the year.
Okay. Anne?
Just to comment on patient-initiated follow-ups, that's one of those things that we're all expected to explore, and CMAST has a work stream on everything. We've got a work stream on patient-initiated follow-ups, but one of the big things about that is the health inequality issue. There's a real worry that you know, the middle-class, able-educated will make sure they get the patient-initiated follow-ups, and the other people won't, and the elderly people might have a different view than the younger people and all this kind of thing. So we're really anxious, given the health inequalities we've already got, that we don't make it worse by putting another kind of hurdle in the way. So we're just trying to be really sensitive to not having you know, an unintended consequence to a scheme that just goes, you know, into that in a way that doesn't consider what the downside might be.
Thank you. Thank you. Are there any other? Helen?
Could I just pick up the learning disability issue, please? So I don't think the response to the question was good enough. People with learning disabilities go, and it is not simply that it's not good enough to leave everybody with a learning disability until the end of the year to their annual health check. It is not efficient. People with learning disabilities go to the doctor in the same way the rest of us go to the doctor, and the best time to do their annual health check is the same time that you're seeing them come through your front door. We know that vaccinations for people with learning disabilities are lower in Cheshire and Merseyside than they are in other places. So as a Director of Adult Services, I just have to say that that response about people with learning disabilities isn't good enough, and that I would really welcome a focus on supporting people with learning disabilities and autism to have better access to health.
Great challenge. Fiona, rather than responding to it directly here, perhaps what we could do is through our chief execs, let's hear more about the total experience of people with learning disability, and what our strategy is to close that inequality gap. Maybe if we could come to a future meeting, perhaps in a couple of months' time. Yeah. Go on.
So just one really quick comment, because the question was specifically about the annual health check target. Yep. I completely agree about access to broader health services for LD and autism patients.
Yes, I think we wouldn't doubt anybody's ambition or motivation ensuring that there's equal access. I think Helen was making a good challenge about the processes that we use to try and deliver some of these important things. Okay, are we happy to move on? Should we go to the quote? Executive Director of Nursing and Care report.
Thank you, Chair. So the report's purpose is to provide assurance regarding aspects of quality, safety and patient experience for the services that are commissioned across the geographical area of Cheshire and Merseyside. So I'd like to highlight a couple of areas within the report and take the rest of the report as read. You'll notice that it identifies that at the time of writing the report, we couldn't incorporate the findings of the recent Kirkup East Kent Maternity Services report, as it was only released late last week. So I will give us a verbal update at this present time. So the report was published. It's an independent investigation that was commissioned in February 2020, and the report reviewed 202 cases, which drew down evidence from family listening sessions, clinical records, and interviews with clinical staff and others over a time period from 2009 to the end of 2020. The report highlights the illustrative cases in there, if anybody has read the report in detail. And there were a number of missed opportunities identified within the review. There's a number of failings within the report identified for that around areas of teamwork, professionalism, compassion, listening, safety incidents, and the trust response, including at board level, to listening to the incidents that had occurred. So the number of missed opportunities, as I said, from 2010 to 2018, and they were raised by both staff within the organisation but also external regulatory bodies as well. There's some actions that have come out of the report which are around monitoring safety and performance, the standards of clinical behaviour, and the issue around flawed teamwork and pulling in different directions. So there are 5 recommendations within the Kirkup report. And the first one is around the prompt establishment of a task force and looking at how in undergrad and postgrad and continuing education we look to further develop how we embed that compassionate care that has been highlighted within the report. So, Chairman, I'd like to take a more detailed report to this through the Quality Committee, and so that we can explore in further detail on what the meanings are for the report and our response as an ICB. And then I'd like to move to a part in the report. So mentioned considerably this morning has been around workforce both within the NHS and social care. And I'm sure you'll agree that within NHS and social care, the greatest strength is its workforce. It's also been mentioned this morning around the publication of the CQC State of Care report that was launched last Friday, which identified a significant gap in workforce across NHS care and social care, and that the focus and attention that is required to address this gap. So within the report, you'll see a piece of work that was delivered on between 21 and 2022. I wasn't in post at the time, but I've had the pleasure of listening to how that piece of work developed. And it was funded by the People Board. It was looking at nursing, midwifery and AHP workforce and what we needed to do to support our workforce moving forward. You'll see within the report it highlights 11 themed areas, and we're now working to embed those themed areas which are crucial to not only supporting recruitment to our workforce going forward, but to ensure that we retain them and that we develop them so that we can provide the highest quality of care. I think that workforce needs to have a greater focus, so I'm proposing that we bring a further detailed report of one of my future Director of Nursing and Care reports, focusing on workforce and across both health and social care. So I'd like the board to note the contents of my report and also the agreement to take the Kirkup report to the forthcoming Quality Committee. And I'm happy to take any comments and questions. Thank you,
Thanks,
Chairman.
Chris. Questions, comments? No, we comfortable? Yep. Okay. Should we move on to continuous glucose monitoring? Lauren?
Thank you, Chair. Good morning, everyone. It is not necessarily usual that this board will consider when new guidance is brought forward by our the NICE organisation that sits out there and guides the way we care for patients, sets the standards within which we work. But this is a particular situation that's come along that is well worth sharing more widely. There are tens of thousands of patients with diabetes who live a really challenging personal existence for them and indeed for their families around them. Injecting themselves several times a day, let alone taking the multiple blood tests to understand whether their blood sugars are heading up, down or otherwise. And the long-term health impacts of living with diabetes for those patients is huge. We've now had some new guidance out by NICE that at last brings forward probably one of the most important changes in the care of diabetes that has been seen in many, many years. Instead of a purely reactive existence that patients live, checking where their glucose levels are up to and then responding with a dose of insulin, we now have some hugely effective technology, continuous glucose monitoring. You might have seen patients out and about with what looks like a small plastic button attached to the skin that continually measures what their glucose levels are and either alerts the patient to variation that they then respond to with administering their own insulin, or indeed now the most sophisticated closed-loop systems that simply respond directly and alter the level of insulin that that patient is receiving. The level of sophistication of this makes the most enormous difference to the long-term outcomes of these patients. When your measurement of chronic glucose control, your HbA1c, when that starts to come down, long-term health conditions can then start to melt away for some of these patients. And at last, we've got really robust guidance that is out there now that as a system, we want to adopt for the benefit of all of those patients that we serve. We've talked a lot today about the challenges of finance, and we speak to that in this paper to the extent by which we can. And what I mean by that is a lot of this is based on modelling and understanding the wider impact of health for our patients, and I will mention some of that today. Right now, our patients with type 1 diabetes, so these are patients who early on in life had a pancreas that failed and won't make the insulin that they need. Already within our healthcare system, nearly 3/4 of patients are starting to access continuous glucose monitoring, 72% of them. But there is significant variation. Depending on where you live in Cheshire and Merseyside, that can be as good as 83% or as poor as only 55%. With guidance coming forward, we are determined as a system to bring that into play for every patient and to start to challenge where we have variation. We know that patients suffer hypoglycemic episodes that bring them into hospital. We know that it destroys the microvascular circulation. So that drives trouble with renal disease and patients moving on to dialysis. It causes irreversible blindness. It results in damage to nerves so that people lose the sensation in their hands and feet and can end up with amputation because not only the nerve's damaged, but the blood supply is. So whilst we are modelling that the cost of bringing this forward is in the region of about £3 million each year, certainly as a system we can get more efficient. Procuring across the whole region means that's likely to come down by 1/3. Also, the devices are getting cheaper as they're being scaled up. But the benefits for our patients, quite apart from that quality side, it's really difficult to keep your job when you have to go for dialysis 2, 3 or 4 times a week. But to speak to the challenges that we face financially, some of the modelling is now suggesting that we will probably save £500,000 in patients not arriving at ED with hypoglycemia. the impact of having a limb amputated in purely financial terms might be £2.5 million a year. But the impact on those patients is lifelong. The impact on their families, indeed, can be lifelong as caring responsibilities come forward. So whilst I would like to commend this paper, that the quality impact is huge to our patients, I would expect and indeed demand of our system that we look to properly measure that return on investment long term to evidence how this plays through for our system, because we must remain financially sustainable as well. And we will commit to understanding that return on investment. I will pause at that point. I hope that's a narrative that is helpful above and beyond the paper that is written, and I'm very happy to take any questions from colleagues.
Questions? Ruth.
Yeah, thank you. I really welcome this initiative. I think the benefits to patients are potentially amazing in terms of that improved care for diabetes. And I think my concern is just on paragraph 4.2, where it talks about, and you mentioned about the variation and about those being aligned to inequalities. And I just wanted to know what our commitment and action is to make sure that those who would benefit most, and that we're not going to widen inequalities, but actually we're going to be really proactive in trying to reduce them, to make sure that people who may be less able to use services or have a lesser voice, or actually we're giving them the voice to make sure we are reducing inequalities in this.
Thank you, Ruth. There's no doubt that has to be a very substantial part of the technical plan that deploys this, that seeks to be assured that we are finding patients who often will have most to gain, because patients from areas of deprivation in particular, they live with diabetes, but they also have cardiac disease, respiratory disease, battling with a raised BMI as well. So yes, we will be expecting and asking our teams that are deploying these technologies to look to report back and demonstrate how they are reaching deep into our communities for those who are hard to reach and find. And helpfully, some of the technology that's coming through, not for diabetes, but understanding our public health, because we know where patients live in deprivation, live with this diagnosis, we know which GP practice they are registered with, we are able to then follow those patients through and again seek assurance that they are being actively sought to be offered the best care possible. So yes, it must be part of the way we deliver this. Thank you, Ruth.
Adam?
Yeah, firstly, just completely agree with the proposal. I think it is life-changing for patients, and in my own clinical practice, alongside feedback from other pharmacy contractors, patients who will be eligible for this are very keen to benefit from them. Certainly there's some very proactive patients who are very keen. The difficulty I have is with the detail of the implementation and the volume. I think the amount of people covered by this is huge, and the resource in primary care, both in general practices and in pharmacies, is crucial and really needs to be provided for, rather than what we've seen in past implementations is patients just landing into a system that's already under pressure, needing help and leading that healthcare professional in front of them with the moral obligation to provide technical support, clinical support, as well as just the advice and reassurance that they need without any resources to doing so. And I think that's moving pressure onto contractors who are already in such a perilous place, as we've heard a few times. So I think the implementation plan's mentioned, but the detail's not there. So I think we do need to capture that detail, including whatever elements of that financial support are out there for contractors that will be necessary to help patients through this.
I completely agree, Adam. We need, again, to seek the assurance as this is deployed that it's working well. What's really interesting is a lot of this will be led by secondary care, particularly for our type 1 patients. But I've been really pleased to see not only the input from healthcare, but indeed the Steve Morgan Foundation is investing £5 million into Cheshire and Merseyside for a wraparound for the paediatric population as well. So that is providing an entire sort of support platform for youngsters who are making their way onto treatment. Steve and his family are very upfront to share that within their family, this is resonating very personally for them, and hence are investing, particularly in that paediatric side. Yes, we will expect to see that everything is put in place to make this work as effectively and efficiently as it can. I'm delighted that we now have our chief pharmacist in place, who is extremely cited on the way all of this plays out, and indeed that we capture the impact of it. I also know a further £50 million in funding from Diabetes UK adds further into the research side of understanding the way this plays through, and we will be happy to report back through this board how this progresses. Thank you, Adam.
Steve?
Thank you very much. Really welcome the paper. I mean, clearly it's a medical, preventative, but a financial issue as well. And the £3 million you mentioned is a significant figure we'll have to bear in mind. I notice in the recommendation you have a task and finish group to look at the ability for us to consider that within our financial plan and indeed our strategic plan, which we have to produce by the end of the year. I really think we should support this going forward. Really interested to hear from our GP colleagues its importance. It's about community health, it's about individuals' health, reduction in heart attacks, microvascular reductions and amputation issues. I think we really should make this investment, but clearly we've got to make sure we can afford to do so, because our budget's going to be under enormous pressure. We're not quite certain with the Chancellor's budget statement, which is coming I think not on Halloween, but 2 weeks later, what it's going to deliver for health against the pressures. So I'm really pleased that we are considering this. It's a big step forward in terms of preventative health if we decide to proceed with it, Raj.
Thanks, Steve. Tony?
Thanks, Raj. And an excellent, well-presented report. Ruth raised an issue about the need to ensure that people from deprived communities can access this excellent service very well, and we've just heard other comments there about the need to implement this thoroughly. If we look at people from ethnic minority backgrounds, are issues raised from that need to be addressed in the implementation plan and the further monitoring of this proposal?
Thank you.
There certainly are, because we also know that when we look across the groups of patients who live with diabetes, again, there is a disproportionate representation of patients from ethnic backgrounds. And already our diabetic clinics led out of secondary care are producing a wealth of resources that allow them to very effectively speak to those populations, whether that's looking at diverse languages and how information is provided in those languages. I don't doubt that, again, we will seek the assurance that our teams will use the skill set they've developed already caring for these patients to move them, hopefully, into a set of care that makes their lives easier rather than more challenging. But we'll make sure they remain sighted on that. So thank you for your question.
Thank you. Claire?
Yes, thanks. And so my comment sort of links to what Steve was saying as well earlier. So I fully support this proposal. We had quite a sort of healthy debate, didn't we, at executive meeting before the paper came here. And yeah, you know, it is an investment, but the clinical case is really, really strong, quite clearly. And I think this is going back to earlier conversations about the real importance of being able to deliver efficiencies where we can, means that we can invest in this sort of thing. And, you know, I really welcome what Rowan said about developing that, the business case and the value for money review over time. So happy to support that. And I think if we can get really good at that, it really helps us become innovative and invest in things that will have an impact in health, improving health further down the line. So just to provide my support, really.
And to respond, this may well represent one of the several opportunities that we have as a system now, because it's really hard for one trust to provide, for example, all of the kit and setup for these patients at a particular cost and say, well, where's the value for money if they are then avoiding going to the renal dialysis unit that is down the road and under a completely different organisation to mine? The benefit of a system is that we live with a single bottom line, and as such we must try and realise the opportunity to capture the impact of this from across that entire system. I don't believe that's necessarily a really easy thing to do. Getting into the health economics is a really complex place within a complex system. But that doesn't mean we shouldn't have the ambition to properly realise the benefit of the healthcare that we provide. So look forward to working on that. Thank
Chris.
You. Yeah, just to say, make sure we work with our voluntary community faith and social enterprise colleagues, part of the system, they're the closest, to the communities that we're talking about, deprived communities, those that are, in most need. So working collaboratively, I think, is going to be really important with this.
Great point, Chris. Thank you. Right. I think what we've heard this morning before we come to the decision that's here as a recommendation is that we must understand and see a progression on tackling inequalities. Adam's point about implementation, we really need to see a thorough implementation plan that includes all sectors that are going to be involved. And clearly we've got the question about budgeting, which we made good discussion on. So in light of those things, and I'm going to suggest, Ray, forgive me for making this up as we go along, it'd be really useful to see the progress that's been made on this at a future board meeting. Perhaps 12 months, so this time next year, if we can log that in to our work plan, is that sensible? Right? Let's understand whether we have made those differences to tackling inequalities in addition to the decision. Actually, I need to go to the decision first, and then I can ask for a review. Let's go to the decision, which is, do we agree to retire, I think is the word, current CGM policy? Yes. And approve the recommendation for CGM for flash glucose monitoring in accordance with the NICE principles. Yes. Good. Let's see that back in 12 months' time. Thank you. Good discussion. Joe, are we ready?
Yes, we are. Thanks very much. If I could have the first slide, please. So this is an update on the provider collaborative that looks at mental health, physical community services and learning disability services. The members of this collaborative are along the bottom strip. So this is a group of organisations that either provide some of these services or all of these services within an individual organisation. These are often misunderstood or not well understood services. Nearly everybody who benefits from mental health community or learning disability services are almost by definition very vulnerable individuals. A lot of this is done in a community space. Some of it is done in a bed-based space, but we manage a great deal of risk in these services. Historically, they've often been variably commissioned by PCTs and CCGs after PCTs. So it's not across Cheshire and Merseyside for these services a level playing field. It's actually very variable. This collaborative, I think, works very closely with the interface of the CMAS collaborative that Anne represents here, but also it's a very natural space where primary care, where social care, where the community, voluntary and faith sector intersects. And actually it's not unusual for the providers in this collaborative to be multiply in touch with just about every type of civic organisation you can imagine. So it's important, I think, to start to view this collaborative as a really important mechanism for the ICB to begin to think about having lots of fingers out in many, many different types of civic relationships. So that's a little bit about why it's important, in a sense, to have the collaborative. The title is about collaboration at scale to enable better care at place. So the collaborative is not actually about abstracting stuff to a level at Cheshire and Merseyside that ignores the fact that we sit really, really closely in place. And indeed, much of what we do is well below place. It's in neighbourhood context. The rest of the presentation is a little bit about a conversation we had with Raj and Graham last week about how could we use this sort of collaborative to build something around a greater than the sum of parts relationship between all of these providers, between the ICB itself, which we're one and the same thing. We're not different. We're one and the same thing. And really use those relationships with place to make place real engine houses of change and innovation for the groups of people that we work with. So next slide, please. Describes a little bit more about who we are. But the provider group along the bottom has a combined budget for provider services of about £1.5 billion, and that's a significant slice of the provider budget of the ICB. It's about, I think, 23%, something like that. And there are 20,000 NHS staff working in these services across Cheshire and Merseyside. And as I say, we represent a head-to-toe birth to grave sort of set of services. So we really are a significant opportunity to think about, when you think about ICB being set up on the basis of the white paper, to really think about the movement into large-scale prevention, into very close working relationships with our other civic partners and so forth. Next slide shows that we've already done some of this work, and we're sort of ahead of the rest of the body of the collaborative. This shows one example where the two mental health trusts in Cheshire and Merseyside and the independent providers of forensic mental health in Cheshire and Merseyside have already worked together to look at a co-produced and agreed clinical model for low and medium secure mental health patients, so patients who will, under the Mental Health Act, either reside in, for a period of time, a low or medium secure mental health facility. And what's really been different about this piece of work is we have, over the last few years, negotiated with specialised commissioners, NHS specialised commissioners, where this is normally commissioned from, to take the budget into the collaborative and begin to use the sort of collaborative skills of the provider group to think about reforming our pathways in a way that we've probably all wanted to do but not been able to do because of the way the system has been structured around commissioning in the past. And this isn't just a set of mental health providers speaking to each other. Really interestingly, we've worked with social care representation, in this instance from Sefton, but representing the whole of Cheshire and Mersey social care, and with place leaders, in this instance in Liverpool, but representing all of our place leaders, to say, look, how do we use this opportunity to really create a much better, more integrated pathway for these the patients who would use these services, most of whom are really, really complicated people who come from, of course, homes and communities in Cheshire and Merseyside and need to go back to those homes and communities in Cheshire and Merseyside, but will pass through some very complex services in the process, including our criminal justice system. So people who come in and out of medium and low secure mental health services often come from or go to a spell in prison. So if you look at what we've done in this collaborative, we've agreed a single standard access and assessment protocol right across Cheshire and Merseyside. So people who often get left behind are now assessed in a very, very common and systematic sort of way. We've got common medium secure and low secure referrals admissions panel. So rather than doing this multiple times across Cheshire and Merseyside, it's done once. It's done once with common agreement. And interestingly, that's done once with the independent mental health sector as well, not just the NHS. And what we've seen as a result of this is a reduction in waiting list numbers and waiting time access, issues that we've been trying as individual organisations to crack for, as long as I've been around this, to be quite frank. And given that the individuals who are in these services suffer extreme health inequalities, actually, being able to reduce that waiting list number, improve access time, is a really significant benefit to making sure that most of the men and women who go through low and medium secure can return in a more recovered state to their populations. We've reduced really, really significantly the number of medium and low secure patients who receive treatment outside of Cheshire and Merseyside, which is again significant for people's ability to move back into community-based settings. Targeted work with patients to significantly reduce length of stay as well, so better for patients, better for the public purse, and to support pathways out of secure care, including new community forensic services, so we can manage people really, really much more safely into or out of these sorts of services, but from their local places. And we've got a great clinical oversight group. If we took all of this ability to manage our own resource away tomorrow, the big remaining benefit would be clinicians are talking to each other in a way that they've never done before. So that in itself is a huge benefit. And being able to direct our resources from a traditional bed base into new service development. So a new prison pathway team, specialist community forensic teams that now cover Cheshire and Merseyside, learning disability and autism community forensic teams as well, because often this group of people, either severe enduring mental health or learning disability and autism, are often people who are targeted by organised crime, by gang culture and so on, and can inadvertently end up in the criminal justice system. And this is a real opportunity for us to make sure that the default scenario for these people is not prison. And we are at this point in time trying to look at an autism-specific then inpatient services pilot. So the reason I've dwelt on this for a while is it's a real big significant win. We have two other mental health provider collaboratives inside the collaboratives, one on adult eating disorders, one on CAMS. And those are really starting to show significant and similar benefits to what we've done here. So for the next slide then, this is making us think that a proposition we can make is to consider taking some delegated responsibilities and budget from ICB, and for this collaborative to be the convener of our system at scale. So reducing the large amounts of unwarranted variation we have across, for example, community services, mental and physical health. Why do we see so much variation around the point that was made about people with a learning disability and access to some really simple stuff, but it is hugely lumpy across the ICB. Improving equity of care, I think it needs to be better than that. It needs to be about programming equity as we move ahead and delivering better outcomes. And then improving productivity and value for money as we go. So we've already, we describe here some real opportunities, I think, to turn this thing that we keep talking about euphemistically at times, I think, which is population health management, into a practical set of deliverable objectives that will deliver benefit for patients. So the reduction, identifying and reducing unwarranted variation in service delivery. We've got lots of examples now where that needs to become a real thing. Fully integrating mental health programs with physical health programs. So much of the work we do shows that nobody has a mental health problem or just a physical health problem. You know, people have all of these things all of the time at the same time. So our ability to see the person rather than the diagnosis is really, really strong in this proposition. Developing the NHS at home offer. So I wonder why we still have to do lots of these health checks through general practice when we could be using technology to do lots of stuff for people who have traditionally found it difficult to access care. And that's not just the rollout of virtual ward, but much better technology. Working with Place to develop consistent offers for population segments that are very challenging, frailty, for example, or complex lives. We know that these groups find it incredibly difficult to negotiate the miasma of different organisations they've got to go with, and we could create much more simple, better outcomes and probably more financially effective approaches to deliver the services. And then there's lots of other stuff we could do, needless to say. So add-in value, what are we doing? Next slide, please. What are we doing now? There's loads of stuff we've done, from the sinkhole services, the complex step-down stuff that we've done in some parts of Cheshire and Merseyside, the delivery of oximetry at home, really specialist COVID treatments, the monoclonal antibody services, the continued development of urgent treatment centre models, the reduction in variation. So we spent a lot of time talking about waiting times for acute services. We spend very little time talking about the very long hidden waits that can be for many of the services that we run. So this is a collaborative that has already started to put that in full perspective. Lots of improving workforce flexibility. And I think we've been leading really strongly in using collective intelligence. So much of what we do depends on doing other stuff with other people really, really well. So the CIFA program that the collaborative has been critical in putting in place is giving us a much more intelligence-led approach to where we go. Not just in terms of where we go in the next couple of months, but where we probably need to go in the next 3 or 4 or 5 years. And then just on the right-hand side of that, I mean, our proposition will add value. But particularly we think primary care and third voluntary and faith sector colleagues, where we need to be much closer. And we think having not absolute control of budgets, but where we've all got a responsibility to work more effectively together, then making sure that everybody's got skin in that game is going to drive us further, faster than we've done before. And I think there's a real issue in this collaborative about thinking about sustainable commissioning of sometimes what are small services but are really, really critical locally to maintain sort of benefit to people. I think particularly some of the stuff we do with the third and voluntary sector, there's just essential that we make that more sustainable. Or other fragile services, and sometimes those fragile services can be quite big, but suffer, for example, workforce recruitment or cultural issues. I'd refer there to some of the stuff that you've seen recently in Panorama programs about, closed mental health units, where we must make sure that those services are really safe and culturally open, and that's a big opportunity for us as we go here. So next slide, please. Just a quick flash on this slide to say there are 4 sets of objectives that ICPs have and ICSs have, and we've mapped our offer across those, and you can see how this is a sort of fundamental offer to the rest of, to build in the future. Next slide is about governance, and you could spend all day saying why this is wrong, but it's only there to say this is a governance slide that knows we've got to get the governance right on this. This is about our system coming together. It's about the management of risk in a different way, and it's about us beginning to think about opportunities to move our resource around in a different way, to target it in a way that I think historically CCG and before that PCT commissioning failed to do. So that's not written stone, the governance. It's just there to say we know it's really important. And on the next slide, we've got a proposed timeline, which again is not written stone, but I think when we spoke to Raj and Graham, there was a request to have a strategic outline case on how we would develop these sorts of functions further and faster, which is shown on the next timetable on the next slide. We can leave it here at this point in time, but that's a roundup of what we've done, but on the basis of what we've done, what we could do.
Thanks, Joe. Really interesting. Just in the interest of time, because
yes,
time is running away with us. As Joe has said, there's the intention to bring a strategic case back here to the board for full consideration, both of the proposition and the governance arrangements. So can I ask people to limit their questions or the comments, the things that you think will be helpful to Joe and colleagues, or of course you're able to do that outside of the meeting. Ruth?
Yeah, thank you. I really welcome kind of the focus on prevention and thinking about people as whole people, and I just picked up some of the risk factors for in terms of thinking about drug and alcohol, people with communication difficulties, employment. I think financial stress is something that we're going to see more of, and housing insecurity, poor diet and isolation. And so I just wanted to kind of ask and thinking about how we're doing that more of that social prescribing approach, so that we really are kind of thinking about that prevention and support for people all the way through their pathway of care.
I agree.
Okay. Steve?
Thanks very much. Just need to try and understand how this would fit with the plans and the priority given to places. I need to understand how this will give support to or complementary support to the place-based agenda, the 9 places. Because some of the issues you're trying to achieve here, for instance, the one on working on frailty and complex life, I would have thought that would be a real priority at place-based level. I need to make sure this is complementary and doesn't compete. When you're asking to be a convener, you're asking for delegation of resources. What does that mean to place? I need to understand that. And how does it also fit with social care and the work of local authorities? So I've got some reservations, Chair, about this at the moment. I think I need a conversation around this to make sure I've got full understanding of it.
Thanks, Steve. Joe, can I suggest you've noted those questions, and we will have full opportunity to debate it at the strategic case level, Steve. But of course, Joe, I'm sure you'd be
Steve,
happy to speak to Steve.
I'm happy to speak to Steve about that and others, yeah, of course.
Are there any other questions? No? Thanks, Joe. Really interesting stuff. Can we go on to Claire, outline approach to financial recovery?
Yeah, so this is the request of the board at the last meeting to bring back a sort of a bit of a stock take really on how we are undertaking financial assurance in year around delivering our financial plan. So there is clearly a significant amount of work still to do in this area. So what the paper describes is some of the assurance processes that we put in place in part with our partners as collaboratively across the system to develop the plans themselves this year that we've signed off and individual boards have signed off, and how we did that and our approach to that, how we are currently monitoring, tracking and escalating any issues associated with delivering those plans in individual organisation level at the moment, and the work that we intend to do to further refine that around developing a financial accountability framework for the system. And you'll note from the paper that we have a Chief Executive workshop in a couple of weeks to further co-produce that with partners in terms of what that looks like and what different parts of our system have responsibility and accountability for, and how we will hold to account. So this is by no means a finished product. It's sort of a set of tactical arrangements that we've got in place to get us through the next couple of months. But I do anticipate that this is very much an area for development for us. The other thing I've just flagged in the paper is around our approach to developing a financial strategy, because clearly that's critical importance as well when we think about how and when we kind of deliver the plans around financial sustainability. So I've flagged up in there, you know, lots of work on that to do. National guidance expected in December, with Q4 being a very, very busy quarter for us then, in terms of pulling all that together and thinking about what that means for us in Cheshire and Merseyside, given the financial challenges we've got, and how we are going to tackle those together, probably over the next 3 to 5 years. So very much still waiting on guidance, on allocations, on the financial mechanisms that nationally will be put in place. And I'll update the board on a regular basis as that landscape crystallises. So the recommendation for the board, and then is really just to note the contents really of that paper, but also to provide any feedback at this stage, if you do have it, that we need to consider as part of our development of the financial accountability framework going forward.
Thanks, Claire. Any urgent immediate feedback for Claire? Otherwise, I'm pretty sure she's happy to receive it.
Absolutely.
Outside of the meeting. Hugely important piece of work, as we've referenced throughout the meeting. Thanks, Claire. Anthony, can we go on to winter planning?
Yeah, thank you, Chairman. So yeah, the paper's titled Winter Planning, and I guess to some extent that's a slight misnomer really, in the sense of, you know, a number of years ago we would have gone through a process where we bidded against additional winter plan monies as recognition of the increased pressures that presents itself on the urgent care system. But as we've talked about earlier in the agenda, the urgent care system is already under a great deal of duress, and therefore what I'd like to do within my narrative is try and give a bit of an overview on things that were taking place already in terms of action, and then some of the further things that we're trying to put on top in terms of winter planning really. So as I say, the paper's quite detailed in its construct and talks through some of the processes that as an ICB we do need to follow in terms of regulatory approaches, national expectations. But just to say, the way in which we've dealt with that as a system is that we have a weekly winter planning operational group which is constructed from every single provider, every single place. And that's the way we keep the battle rhythm going in terms of the development of plans, the collation of the plans, and the learning predominantly from individual places. So those plans have been developed, as we say, and over the past week or so we've been holding a series of place-based reviews led by Graham, where we've been asking all parties to talk through the plans, but also the wider aspects of current urgent care provision and challenge. The remaining 6 will be taking place over the course of the next 2 weeks. And it may be at some point, Chairman, that you may wish to have a further update from the output of that and some of the other bits that I'm about to talk about. So, as we've said, you know, and we described early on some of the real challenges we've got, but where we've tried to focus in terms of the priorities really across 5 key areas really, recognising that there is additional funding available, and we've took the opportunity obviously to draw that down, but also this is probably a winter of where we have to maybe look at the way in which we currently provide services and reconfigure them, even if it's only in the short term. So you'll see within the paper there's a reference at table 1. So this actually is probably more of a normal tactical response at this time of the year. So the system has secured close to £14 million worth of additional funding to mobilise 205 more beds in the settings that are set out in that table. We're absolutely on track for the mobilisation of those. In fact, some of those schemes that were set for November have been brought forward into October. And that's a real critical factor for us. There's a very strong performance framework around how this money has been utilised across systems, and even a commitment that should systems be struggling to mobilise some of that plans, money may be withdrawn from those systems and allocated to others. But we can absolutely say right here that these plans are extremely robust, and we're already delivering some of them in advance of set out. To follow through on that discussion around probably some of the 999 calls, and also about the reworking of existing services, one of the key component parts we see of this year's approach is our fall service. If we look across the 9 places of Cheshire and Mersey, on the whole, there's a really robust proactive fall service evident in all of those systems. But there's a greater deal of variation in terms of reactive fall services. So that's the type of services that can respond to falls in the home or in a nursing home, which at the moment can sometimes impact on our ambulance service colleagues. And we've been working with places and testing out through these reviews. Is there anything that we can do to strengthen that falls pickup service, if you like, that reactive service during the winter period ahead of a further review of the entire model? So that's a key component for us. Joe's made reference in his presentation to the approach around virtual wards or building upon virtual wards, and board members will remember 2 months ago when we met in St Helens, we approved the rollout plan for virtual wards over the course of this year and next. Very much the focus at this point in time is making sure we make use of that capacity. Occupancy levels in the current virtual wards is round about 30%. So that whilst that's not significantly out with any other system at the moment, it offers up a massive opportunity for us to try and make use of that capacity. And I think when we look at that in some detail, we see most of that usage is coming out the back door of a hospital. And Joe's quite rightly said in some of his slides about, you know, it's about admission avoidance into hospitals. It's about trying to get patients into those settings up front. Again, we've been looking as part of that review in terms of mental health provision, in terms of what the plans are for obviously that. I think it's fair to say that the mental health services have received a smaller amount of funding. I think it's less than 1 million in total that Cheshire and Mersey received, but they're employing that to good use. And in terms of the ICB's support around that, a recommendation is coming to executives next week on a reworked and extended service which provides mental health transportation from the acute sector and working with the independent sector in terms of care for patients in the acute setting when the mental health providers are dealing with obviously a great deal of pressure already. And then the last point which Steve mentioned early on is clearly that what is the 500 million or our proportion of that being used to. As Steve has said, and as we found out through the reviews, there is a great deal of evidence of services and approaches being worked up. We just need that green light. And as Graham has highlighted, you know, we are hopeful that clarity will be provided in the forthcoming days, which will allow us to mobilise that as fast as we can, because we know that's an absolutely massive area for us in terms of opportunity and need. So I'll pause there. Oh, sorry, there is one final point that there's a big ask, and I guess it's an ask of all ICBs and probably paves the way for maybe a sign of how things will start to emerge in terms of the national, regional and ICB links. In that we've all been asked as part of that going further on winter guidance is to set up what's called a strategic command centre or a strategic coordination centre. Now that's quite an extensive ask on the timescales that we've got, but I think it is building upon systems that we've had previously where the system tries to pull together a real-time information about how urgent care pressures in particular are manifesting themselves across all sectors and act to try and pull levers to try and balance that demand in real time across that sector. So we've been doing a number of assessments on how that can be done, working with our fellow ICSs, some of our regional colleagues, but it's very clear that the line is expected to flow direct from national to ICB, which is a different sense of direction in how that's been performed in previous years, and obviously working with providers in how we can mobilise something on that. It's a big ask, and as I said earlier on, it might be that if the board requests, or we can do it through a committee, that you receive a further update on our progress towards that, with an expectation of go live on the 1st of December.
Thanks, Anthony. Any questions or comments? Ruth?
Just a couple of comments. I know we talked about vaccination earlier and really so important. I just wanted to mention it's pneumonia as well as flu and COVID that we need to be focusing on, and also children as well, because the fastest rise in admissions has been in children under 5, and we've already seen flu circulating. So it's just to kind of make the point that it's adults and children vaccination. And I think the other thing that I just wanted to note that was perhaps I didn't see a lot on respiratory conditions. And I know there was a report by Oxford University recently that people with COPD are 50% more likely to be impacted by severe illness around COVID and things. And so I just wanted to make sure that we're thinking, particularly with cold homes, that there's going to be a real risk for people with exacerbation of respiratory conditions, and so I just wanted to make sure that we're really thinking about that on our approach to both children and adults with respiratory.
Thanks, Ruth. Questions or comments? Just can I make an observation? So it feels as though this is very NHS centred, and of course winter does happen in local authorities and the voluntary sector. I know in place that there's an awful lot of collaborative working happening across voluntary sectors and local authorities. It would be really good to understand the totality of the ICS's winter plan. Tony, if I can ask you to think about how we could see that, and of course our colleagues from the voluntary sector and local authorities, be good to hear from you. Steve?
Well, one example of that would be development of warm places. We're all looking to establish warm places for people with difficulties with energy poverty at the moment, and that's a really good example of how we could work together as a system around those areas.
Thanks, Steve. Our colleagues in voluntary sector, just give us a vignette of some of the things that you might be thinking about or doing.
Yeah, I mean, there's a whole range of initiatives being developed, certainly in Cheshire East, and I'm sure across the rest of the boroughs at Cheshire and Merseyside level. There's a real focus not just on, you know, some of the winter issues, it's the cost of living crisis as well, so these things are massively interlinked. There's a lot underway, is what I would say. Yeah.
Thanks,
and we need that collaboration. It does need to be cross-sector with the voluntary sector again, which is closest to the communities that we're trying to support.
And Mark, from a place perspective, any support or anything that you want to add to the conversation?
Well, it seems to me that I think you've kind of raised the distinction between what the ICB does with its kind of perhaps more NHS-oriented responsibilities and the broader ICS and kind of bringing in the ICP. From a place perspective, we've got a kind of close to final draft winter plan. We're discussing that at the Council's leadership team meeting next week. It's going to our Place Partnership Board also next week, and that isn't just an ICB kind of response in the narrowest sense of that. That is the kind of broadest, the kind of place-based response, and does link in with partners that Chris represents as well.
Thanks. And Mark, if I would just say this to you, the ICB, of course, isn't just about the NHS. We've got, you know, a set of strategic objectives that includes things like social value. So it's right and proper that we bring together around this table, you know, the totality or indications of the totality of the work that's going on at a place, but also understanding what we think we could contribute from a Cheshire and Merseyside perspective to each place's ambitions to manage winter as effectively as possible. Right, any other views or comments on winter planning? I feel we're all equally anxious about this winter for very many reasons, for all those reasons that have been articulated. Can we go on to the report of the subcommittees? Tony, Remcom.
Thank you, Chair. The Remuneration Committee met on 2 occasions, and the report details the areas considered, particularly summarised in the exec summary, and then in section 3 there's further detail on the partner member remuneration discussions we had, and also the decision made on the national pay award for very senior managers. Could I just ask you to note those, and then also in section 5 we made some minor amendments to the terms of reference that required the board's approval.
Thanks. Is there any questions on the main body report before seeking your approval on terms of reference? Comfortable? Approval for the terms of reference? Some nods, perhaps, or yep. Thank you. Thanks, Tony. Will you go straight onto Quality and Performance Committee?
Yes, just to pick up some of the highlights, and we've had some discussions about some of the items I would have raised, so I'll be very brief here. One of the significant areas we covered was cancer, and we had, as well as looking at the performance on cancer standards as a natural part of Tony's presentation, we received an excellent overview of work done on the Cancer Survey and the Cancer Alliance. Particularly impressed with the work carried out by the Cancer Alliance, which allowed us to triangulate, if you like, the performance on cancer services, but also getting the views of people who are going through cancer treatment and their carers. So that was an extremely strong message that we received there. It's covered in section 2 of the report. We were going to escalate this to the board. We've also touched on this and covered it already, is the annual health checks for people with a learning disability. We've had a healthy discussion there. It's safe to say that that will continue to be discussed at the committee, and also will be raised. I think we'll have to find a different form of this. People are dissatisfied with just looking at annual health checks. We'll need to look for alternative evidence to deal with that, but we'll continue to monitor the improvements that Fiona's pointed out we should expect on the annual health checks. There were some maternity issues discussed, which Chris has already mentioned in one of her reports, and this will be sent to the system quality group for a further analysis. This is a group, a very wide-ranging group that will look in depth at maternity issues, and then the product of that will come back to the quality committee or direct to the board.
Thanks, Tony.
Yeah.
Any questions for Tony? Thank you. Claire, Transformation Committee.
Yeah, thank you. So this was the first meeting of the Transformation Committee, which provides oversight and assurance for the delivery of our at-scale commissioning and service development agenda. So you can see on page 174 what the committee considered. So I'm happy to take any questions on any of that, and also some recommended changes to the terms of reference, which obviously need board approval. Thanks, you.
Claire. Any questions, comments on this? No. And in terms of reference, happy to support that. Some corrections, aren't there, in that? Thank you. Thank you. There are a number of questions that have been raised by the public, and that will shortly appear. We're looking for our support. If it's not already on our, if the questions and answers not already on our website, they soon will be on our website. Yes, Claire, that right? Yeah. Yep. Thank you.
Sorry, Chair, may I?
Yes.
One of the questions was only received yesterday, and so for at least one of the questions, it will take us a little bit more time to formulate the reply, but we'll get all of the ones that have been received in advance posted on the website later today.
Thanks, Graham. So, closing comment, a really good meeting, some good challenge of the work that we're doing, and I can see month on month how we together as a board are focusing in on priorities and actually using the diversity of perspectives that are around the table to really, really good effect against the mission that we have as an integrated care board. So thank you very much for that. There are a number of good things that we'll pull out in terms of communication to our wider stakeholders from this meeting. I won't run through those. We'll produce them in the normal way and make sure all board members have sight of those. Date and time next meeting is the 28th of November in Warrington. So thank you for your contribution, everybody. Thank you. Okay. So we'll close the meeting, but for those of you who can